Good morning, everyone.
Morning.
Finance Committee will please come to order. Our first item of business is citizens wishing to address the committee. Are there any signed in? None signed in. Let's move on to item 3A. Sharon Clark's not going to join us this morning, but Ben Scott's going to stand in her stead and is going to come up and present our November and December financial reports. Morning, Ben, and welcome.
Mr. Chairman, just so you all as members know, there are important things and there are important things. Ben's going to do a great job today, but Sharon is with her son, who is in a geography B. And they put pictures up of geography, and this young man has to say what river, what country, and what border countries it is. And my comment to Sharon, because she was really torn, my comment was, no disrespect, we have 12 finance meetings, and you got one GOB a year, and you hope that he might make the finals. I just got an update. He's one of the final two, and we're trying to see if he can push it over to the final one.
He's a past champion as well.
He is past champion,
Yeah.
and what we're going to do is when we're going to get his final questions, and we're going to put them up on the screen and see if anybody on the Finance Committee can answer the final GO test. So, but Ben's ready to go, and I think we're in good shape, Mr.
Awesome.
Chairman.
Thank you very much. Welcome, Ben.
Well, thank you. Thank you. I'm lucky that a lot of this information you guys have seen before, and Sharon's done a great job over the last couple of years putting things together in a format. So, but we do have 2 months to cover. We're going to cover the month of November and December. First, we'll talk about some of the stats and then get into the financials. I may not make a comment on every one of the stat slides, but feel free to stop me should you have any questions.
Great.
But we did have strong financial performance for the month of November and December. In November, our admissions were slightly under budget for the month. We had a strong case mix index. Our patient days and our length of stay was higher than budget, higher than expected. We did have about 5 patients that had very significant lengths of stays, 5 that were greater than 100, and 1 individual that the stay has been almost 300 days. And so when you remove those 5, we're a lot closer to the budgeted length of stay. The case mix index, you can see that favorable to budget. Partly driving that is from our inpatient surgery volumes. We've had strong volumes for the first quarter of this fiscal year. The next section, emergency department visits were slightly under budget for the month. Urgent care visits as well. Primary care clinics visits are slightly under budget. We have about 14 open positions in some of our primary care clinics. But our specialty clinic visits, if you can see there from the month of October and November, doing very well. We've had a focused effort on improved scheduling for the GI and the hepatology lab. And so those specialty clinic visits are having a very impact on that overall stat. On the next page, you can see that we've had a significant decrease in observation cases. Inpatient surgeries down below, we have 538 actual on the month on a budget of 435. Outpatient surgeries were trailing budget. And then again, we continue to have a very busy invasive lab clinic doing very well compared to budget in the last few years. In the observation cases tab there, and it's a similar story for the month of December. There's been a number of focused efforts by clinical leadership as it relates to utilization review. There's some new tools in Epic and working with planning, getting patients in the right setting, along with some medical necessity education among staff and physicians. And so, you know, what we're seeing is, from a financial standpoint, we're seeing a positive impact from more ER visits resulting in inpatient stays, you know, as well as probably has a relationship to our inpatient surgery volume. On psych patient days, slightly under budget for the month of November. Clinic visits and ER visits are both very favorable to budget. Leadership and behavioral health has been monitoring length of stay very proactively and beginning discharge planning basically as patients come through and become admitted in that area of service. There's four or five initiatives that are ongoing and active. And the patient days, although they're close to budget or slightly below, they're following a national benchmark very proactively. So, and we'll talk about that in a few minutes as it relates to the impact, positive impact that that's had for the income statement. You can see our FTEs per adjusted patient day at 5.65 with a year-to-date target of 5.72. Payer mix, actually in November and December, we've had a slight improvement in payer mix. I know we had a number of months last year where each month it looked like that we were, maybe seeing a half of a percentage point or a percentage point going to non-payer categories, and we've actually kind of seen that flip in this first quarter. So here we are with the income statement for November. We had net patient service revenue greater than 4% in the month, a very strong month. A line item that you see related to the Texas DISH waiver. If you recall, when BKD was here presenting the audit, we were notified of some information after we closed out the year related to our UC funding. We actually had a past audit difference of about $2.5 million related to that was presented. Now, there were some other items that offset that, and that was communicated. But we recorded about $2 million of that adjustment. Instead of delaying it until later in the fiscal year, we went ahead and recorded that during the month of November. So that's the large $2 million variance that you're seeing there.
We booked most of it in November, and you'll see coming up, we booked the rest of it in December. But then
Yes.
we're done for the fiscal year. So
We're done. We're done until more information comes out related to fiscal year 19 and throughout the rest of the fiscal year.
Is that the reason Dave's cash on hand is down?
It's partly down because of that, but it's actually back up some in the month of December. Also, part of that relates to our tax revenue or tax proceeds. We start receiving a portion of that in November. But as it relates to the waiver, there was a lot of changes in the ruling on the waiver payments for UC this last year, and I know you guys are familiar with that. But there was a lot of calculations that were being reviewed and being weighed in by private hospitals and the other public hospitals. And so that determination was made in November of how those final calculations would be. And so there was a portion of our UC funding that we actually didn't receive until December that in the past we would have received in September.
Just a delay, though, not necessarily a change.
Well, it was a delay in that payment, but we did see, I think our funding came in around $47 million on the year for UC, and it was about $8 million greater than in the previous fiscal year. Acclaim had a strong month in the month of November. Physician encounters were about 3% greater than budget. Women's health and pediatrics were strong volume areas. Let's see. And so with the Acclaim income statement, if I can back up there, total operating revenues were about 3.3% over for the month, and overall, their operations was about $500,000 better than expected for the month. Benefits were favorable. There was other operating expenses were a little bit higher in the month. There was some recruiting for chief of surgery expenses that came through in the month of November. So if you don't mind, let's jump ahead to the month of December. We continue to have a number of favorable items in the month of December as well. We actually had a stronger than budget from an admission standpoint. Again, we saw a similar picture related to patient days and length of stay, and case mix index was very close to budget. Emergency department visits were slightly under budget for the month, as well as primary care clinic visits and urgent care visits. But again, as I mentioned before, related to the emergency department visits, that when you look at prior year, we're about 7% over patients that were converted to inpatients compared to prior year, and year to date, we're about 5% more favorable than budget in that area. So we recognize that we actually get higher inpatient. I mean, there's more resources used for inpatients, but we actually get higher reimbursement, and so often it could have a positive impact on our bottom line. Similar story on the next slide with observation cases, invasive lab, and outpatient surgeries. Inpatient surgeries, you can see that we're actually above budget for the first 3 months, and we're actually above last fiscal year and the prior fiscal year prior to that. So a very positive trend in that area. And then again, the stats are very similar in the behavioral health area, with clinic visits being up and emergency visits being up. So in the month of December, with days cash on hand, you can see that our days cash on hand is up quite a bit from the month of November. It's actually a little bit stronger than it was in December of 2018, but again, trailing where it was 3 years ago. And, you know, part of that does relate to the decrease that we've seen in UC funding over the last 3 years. We have seen about a $30 million decrease. 2017, our UC funding was over $70 million annually. And then, again, with our FTEs per adjusted day, we're at 5.65 year to date versus our year target of 5.72. The connection enrollment over the past 3 months has actually slightly increased through October, November, and December. And we would expect this number to decrease slightly in January because of the re-enrollment of the supplemental patients. So reviewing the income statement, I'll mention a few things about the month and then as well as year to date. Net patient service revenue was very close to our budgeted target for December. We took an additional adjustment, as Mr. Montgomery mentioned, related to the shortfall on UC. And then in other operating revenue, we took an adjustment for our PAP drugs of about $496,000, and that's offset in expenses. And there's some different reasons for that. One reason is that the pricing on our Hep C drugs have come down pretty significantly, and then also pricing related to, if I get this right, diabetic drugs have come down considerably. One of the challenges that we do see there, though, is some of the drug companies are becoming more stringent in the application process with patients, wanting to check and verify more information. And so we understand that that's somewhat impacting our availability of usage of PAP drugs as well. So, and that adjustment basically flows through other operating revenue and then expenses. Salaries were very favorable in the month of December. One of the focused efforts by staff and leadership relates to monitoring overtime pay. That's been a proactive initiative over several months. We actually, in the month of December, were lower than budget for the first time in several months. We also had a lot of, due to the holidays, there were, a lot of people that utilized PTO, and there wasn't a lot of backfilling of wages. And so the month is very favorable. In addition to that, on the first quarter, we're right in line with budget, which is very positive. Benefits, we have seen benefits the last few months, which is somewhat similar to last fiscal year, being a little bit higher with our medical health insurance expense for employees. The new benefit plans will take place in the month of January, so we expect to see some decrease in those expenses. And then down in operating expenses, purchase services are about $472,000 under budget for the month. Year to date, we are about $1.5 million positive in outside medical services for behavioral health. And some categories in contract services, we have some positive variances because of timing differences. Some of those contracts will, speed up and get through the process, and expenses should increase. But the savings that we have seen on the case management related to behavioral health are real savings, and they're not timing differences. So that's also contributing to a very favorable bottom line on the first quarter of the year. And then, down in other categories, we continue to be favorable in other operating expenses. We expect some of those expenses will continue to increase over the fiscal year. A lot of those expenses might be timing differences on minor equipment and computer equipment and so forth. So, got just a few minutes left here. December, Acclaim also had a positive month. Their physician encounters were about 2% greater than budget. They had a strong performance, although it was a holiday month. They had a strong performance in family medicine, pediatrics, women's health, and behavioral health. Yes.
I'm sorry. I have a question on the managed care, Medicare, and Medicaid.
Yes.
It seems to be the managed care portion for a claim is a lot higher on the pay mix than the hospital side. Is that something that we should be looking at? Because one side is 23, the other side is like 10 or something, 10 or 13. And are they not? Because usually those goes hand in hand with the percentage for patient. Or they go to a different hospital under that managed care?
We'll certainly take a note of that. I know that the operational team reviews their payer mix pretty closely from month to month, ensuring that we're looking at our run rates on reimbursement for the various payers. But that's a great observation that we can take back and review. But you're right. I mean, we're serving the same population, so if there is some differences, a great question.
And I think I noticed year over year, a managed care for Medicare, managed Medicare's population seems to be shrinking a little bit from a percentage standpoint. Do you have any visibility since the AEP period done was back in December 7? Have they given us any indication how many people they enroll for next year under the managed care program that are attributed to our hospital?
Related to a claim or?
Both.
At the medical center?
Right.
Okay. On top of my mind, I don't have a quick answer for that.
We can definitely, I don't know that either, but we'll definitely check and find out what that spread would be and try to.
Because usually it's related to particularly IPA or ACO or the enrollment that they convert from other managed care program into this for enrollment, and the enrollment is the 3-month period. So they should have everything wrapped up for their next calendar year, so that can give us some visibility to see how we should plan what kind of patient mix we can have inside the hospital under that managed care.
Dorothy, I appreciate the assist. If next time DT speaks, Ralph, if you could move your mic over too. That way, any way he might turn, I think we'll get him.
She's trying to get stereo out of
Very
it.
good. And Ben, you just passed a huge test. You took a DT question and you did really well, so thank you.
So let me, let's look at the income statement again with a claim for the month. A claim, again, was positive for the month. The salary line item was a little bit higher. Total operating revenues almost 3%. Salaries and related expenses were a little bit higher, but part of that, as we reviewed the financials for December, part of that was a timing difference on the budget spread. I think we were expecting that the volumes will be a little bit lower in December and salaries will, but revenues offset those expenses, and the overall performance was better than budget. So let's see here. I'd like to make a comment. This on the combined income statement, year-to-date for the hospital claim, the foundation, we're about $3.5 million ahead of target year-to-date on the first quarter. So, there's a lot of initiatives that are taking place. The last couple of years, we've had some financial challenges. Leadership and managers are monitoring their expenses on an ongoing basis. I'd also like to mention, which it's included in the budget, but it's also positive for the organization, is that there's a component of the Medicare inpatient rate that it's an add-on for uncompensated care. And we received an increase last year, but we also received an increase this year, and that equates to about $3,000 per discharge per Medicare patient. And a lot of our managed care arrangements are tied to Medicare rates. And so when we see that improvement from a traditional Medicare discharge payment, we tend to see that improvement from a managed care Medicare rate as well. So when you think about the overall picture and how strong the performance has been in the first quarter, that has a positive impact as well. It was built into the budget, but we had some pretty thin months toward the end of last fiscal year. From an expense standpoint, and then, we've had a lot of things fall into place on the revenue side that's been very, very important, so.
Very good. Any questions for Ben?
May I go back to the payer mix? Is that based on gross billing, or is it based on enrollment, or is it based on net billing?
It is both based on gross charges.
On the gross charge.
It is on the charge basis of the information that we present each month.
How hard it is to look at from a payment perspective?
Yeah,
Do you know? With gross billing, is no indication of how much we're getting paid. Because I'm trying to wrap my head around is how much is our enrollment growing, the patient mix growing, or is it because we may have some challenge with coding? Because if it's based on net, then I can tell to see if the ACC score is captured correctly, because you can do everything correctly, but at some of the, I'm not going to say the name, but some hospital information system may only allow 3 or 4 or 5. They just recently moved up to 12 or 18. When you deal with a Medicare patient on the ICD-10 side of it, and if you just plug in to get the payment, you're going to change your risk score and your CMI index, and that's your reimbursement side. That's going to be lower than you expected, because the system is not producing stuff to go out to bill, because it's just billing on the reimbursement, but you at a different rate and give you no ability to change the RAF score or anything like that. So that was why I'm trying to figure it out.
Absolutely.
Because we do everything right. I mean,
one of
there's
the,
no
one of
problem
the
there.
things that we do in the finance area is that we do review basically the reimbursement trends by insurance plans and then by payer. Over time, and because we have to model it into how we value our receivables and our AR reserves on a monthly basis. And so now we haven't probably been necessarily tracking it from a payer mix standpoint, but from a month over month, we do monitor that very closely. But you're right.
You
the
wouldn't be
coding
able to
could have
see that, because the billing side is coded behind the scene that none of you guys can see it. If you look at the medical record, it's there, but it's not there on the billing side. But the payment still remains the same. But from a perspective side of it, your risk score is higher, but from the perspective side for next year, you're going to get caught off-handed, because they're going to come down, and you wouldn't know how they value that patient based on the risk score.
Absolutely.
And I'm not sure how we can bring that together with IT and look at from that totality, because it's beforehand, years past, it's not that important, but going forward, as you switching more and more into managed care, it's going to hurt our future revenue a lot.
Thank you.
All right, let's, if we could, let's take A and B separately. We request approval for those two. Entertain a motion. By Reverend Emerson, a second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Item 3D, entertain a motion for approval. Motion by Reverend Emerson, second by Mr. Petty. All in favor, please say aye.
Aye.
All opposed? Motion passes. Thank you. Thank you, Ben. Great job.
Ben, I think it's good that after you got done, before the vote was taken, you dropped the mic and walked away. That's a good job. The other thing that I would tell you all as members of the board that you need to get prepared for is Sharon's son, Aaron, is now a 4-time winner. So he has put the Chicago Bulls to shame because they're just three-peat. And I would encourage you to know a little bit about the Limpopo River because that's going to be your question. So just get prepared. Yeah.
Good morning, Kelly. Item
morning.
3D, no, 3C, I apologize. Thank you.
Good morning.
Morning.
We would like to present 2 managed care agreements for your approval. The first is for AmeriGroup. We've had a long-standing agreement with AmeriGroup, and through the years, we've added amendments and addendums to the base agreement. We've cleaned up the language and combined all the product amendments and addendums to one new base agreement. The new base agreement also provides a 1-year extension for the current rates.
Okay. Any questions for Kelly?
How does is there anything tied to outcome base of the patient or gaps and all that stuff tied with this contract?
Not in this current agreement, not in the one that we just completed.
So this is just the basic one, no risk reward on our side?
That's correct. We just combined all of the old agreements into new paper.
Okay. So just fee for service based on the regular contract type?
Yes, sir.
Any other questions for Ms. Ford?
Move approval.
By Ms. DeBose, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Kelly. Let's do item D, please.
If you recall, on June 28th of 2018, you approved a new managed care agreement with Cigna Health Springs. This included Cigna's Medicare Advantage and Medicaid Star Plus products. This amendment is similar to all of our other Medicaid Star Plus agreements that allow additional state funds related to Europe under the HHSC's direction.
Any questions for Ms. Ford? Entertain a motion. Oh,
Same question before, like AmeriGroup. Does this have any risk-based type thing?
This is not a risk-based agreement, no, sir.
Okay. Do you know when we're going to move toward risk-based?
We are looking into that. I don't have any contracts currently, or we haven't been offered any contracts currently to include any risk-based, but it is something that we are looking for forward in the future.
Do you know when? Can you give us some visibility? When are we going to move toward that?
No, I don't have that information right now. I know, it may be within the next year.
Okay. Because I'm trying to cost justify all of population health stuff. Because that, if you ramp that up, but you don't get the risk base, you're not going to get, the cost is going to be tremendously high without the ability to gain back the revenue that we need to generate to move toward that outcome-based type thing.
So it is, like I said, there are some companies who are offering risk-based. We haven't been offered any at this time. But we are, like I said, we are looking into it. We're doing our research to try and determine what's the best types of contracts for our department and for the hospital.
Have you looked at the total enrollment? Because maybe that's the reason why our enrollment is down, because we haven't moved toward that side of it. Not enrollment, but the utilization type thing from a Medicare, managed Medicare, Medicaid side.
Not at this time, but it is something that we will definitely look into.
I just want to ask DT, that question you asked, what is the advantages to that?
It's almost like a disrupt type thing, like a better way of explaining it. There's reward when you move toward more outreach, closing gaps, preventive and all that stuff, so that you can cut down the cost of the hospital spend. And overall, you get bonuses for that. So we bring the total cost of care down together with the managed care organization. There's more to share back to the provider and to the hospital system itself. It's moving.
As big as Amerigroup is and as Cigna is, do we have the negotiating leverage to force that? Or does that have to be something that they really come to the table and offer?
No, you're gonna have to request for it and balance that with our population health group, because otherwise, other hospital will pick up that population that we don't know about.
So there are some models out there that we could look at?
I think most of the hospital moving toward that already.
Okay. Any other questions for Ms. Ford? Entertain a motion on item D.
So moved.
Reverend Emerson, a second by Mr. Bose. All in favor, please say aye. Opposed, motion passes. Thank you,
Thank you.
Kelly. Rules. Item E. Good morning, Wanda. So,
Okay,
two motions.
I have 3 contracts for you this morning. The first one is for RF Technologies. This is the company that provides our infant security system, and it's just time to renew that contract. We're asking to go sole source with them rather than putting this out for bid. If we did, we would have to get all new transmitters, and there's a lot of hardware that goes with this, so we would like to stay with the same company that we're currently using for our infant security system.
Okay. This is like the wristbands for the nursery and those
Yes,
kinds of
sir.
things.
It's the alarms that go off.
Okay. First of all, are there any questions for Wanda? On the motion on this, I need also to include in the motion, if you would please, the exemption for competitive bidding. So are you including that in your motion? We have a motion for approval. Second? Second by Reverend Emerson. All in favor, please say aye. Opposed? Motion passes. Item F.
Thank you. Our next contract is with Axogen Corporation, and this is a company that we have been using their implants, but we're seeing our spend going up over the last year or so. This company provides nerve grafts and nerve sheaths that we use in ENT, ophthalmology, I'm sorry, not ophthalmology, oral maxillofacial, orthopedics, particularly in our hands and our podiatry surgery. And because we're seeing the spend go up, we felt like it would be a good idea for us to get on a contract, and that gave us additional cost savings over the next year, and of at least $15,000 and then $45,000 over the course of the contract.
Okay. Any questions for Wanda?
I have a
Yes, ma'am.
As we do more of these sole source exceptions, I'm looking at the explanation of how we track that, what they are doing as their company. And it looks like I get the same, they're telling us the same information. I know for this particular item, the company probably can't do any matching or anything, but does that mean that the company overall doesn't do anything? So I'm just kind of asking if we are looking at anything, because we have a form, but I want to make sure that we are getting some good information. If you have a business, and I might do this product, but for my overall business, I'm not just doing it alone. So some of the companies might be doing some business with small vendors, and that's not part that we recognize. So the folks that's looking at this, is anybody working on this? on your form, or trying to make it a little bit clear. One of the questions we had is, are we setting ourselves up for failure when we say we want to do 25% and then we don't look at anything but that? Okay.
I'm gonna ask Michelle to come up and take the mic, and Wanda will appreciate Michelle coming up.
Thank you, Michelle. Happy to see you here.
Happy to see you. Why don't you, Wanda, move that mic? There's a mic there.
Yes, we are looking at specifics around ability to provide subcontractors in many different areas. The form gives us a general overview of what the organization stands for in terms of their equal opportunity abilities, and we do get that information. In addition to that, we are asking specifically if they have track record or history of what they've done in the past. And so that's a part of what we gathered. But your point's well taken, that what we're seeing in the sole source in the form sometimes is we don't track that information. So the key is that the right information that we're tracking, and is there something else that we can do to give a better picture? Currently, we're working with Scott Rule, our Department of Office of Diversity and Inclusion, with number one, making sure that form is streamlined to make it easier for everybody, and two, making sure we're tracking information or asking the right questions. So we're looking at that, and we're constantly evaluating the best ways to do that, and I think we'll have some things to present in the near future that will help us get to that.
If I could just piggyback on that, just one thing is just, I would just hope that in all of our sole source agreements, that we be careful or align those companies to hold us hostage, that we're the only one who provides this, so take it or leave it. It's kind of the thing. And I was just hoping that somewhere we would do some type of marketing, whatever, to say we are at MBE, WBE, yeah, and we're what a percentage we look for you to reach that, even though you are sole source.
Yes.
For sole source, is it because they're the only one, or is it because we didn't have time to go do an RFP, you know?
No, they're the only company that provides these type of nameplates, that's what I understand.
Is it safe to have an option for after 12 months, so that if something comes up, we should go back to an RFP process, right? Right, come up, right. Or we didn't know that there are other companies, so that we can have time to do an RFP. Hopefully they win again, because we're confident that we have with them inside our shop, but we should have the ability to go back to an RFP process. If we need to take a look at and move things for continuity and to take care of our client, but we should have that ability to go back within a year to do an RFP. If it's still sole source, so be it, right? But I'm not comfortable for a 3-year sole source, because that's a long time to lock something in that we may not have the ability to see that there are more company out there that doing that, but we didn't know.
Sort of out clause, if we find something else in the market that, I like
I
it.
think if we had that language in there, that would speak to your point, and that is you may be sole source now, but you may not always have that status. And I think when you get into a level of comfortability, that's when you could create problems.
Right.
And so I think they need to know what our standards are, but also we're constantly reviewing to see if the marketplace changes or if there's somebody else in that market. Because like DT, it might be a little bit difficult to think that is, and some of these are truly a company, but some may not just be a company. And if a new company comes in the market, how would we know? And I think we have to figure out how we best monitor that.
The other side of that, though, is you're probably monetizing savings by entering into a 3-year agreement. And if you alter that agreement to say, okay, we can opt out after year 1, you're probably going to also have to assume that you're going to have to forfeit part of the savings that was contemplated in the 3-year monetized agreement. So, I mean, I'm not against it, but I'm saying there's probably both sides that we have to look at from a cost perspective, too. So,
Yeah. Good points.
DT, I think this contract actually has a 60-day out,
in the event of,
just early termination. Yeah.
not necessarily
For convenience, yeah, for convenience.
But if we don't have a process to know that we have a 60 days out to do an RFP, we won't look at it until it expires anyway. That's the challenge I have, is that if we don't have that process in place.
Okay. Any other questions for? Okay, no, great question. Okay, so I'll entertain a motion on item D. Item
Okay,
E.
second.
F, I knew that. I was testing you guys. Y'all did well.
Are you here today?
Item F. We have a motion by Reverend Emerson, a second by Ms. DeBose. All in favor, please say aye. Aye. Opposed? No.
Yes.
Motion passes.
I want a 1 year out.
Got it. Thank you.
Thank you, Michelle.
Yeah, clarifying that motion was the exemption as well as the motion for the contract, so. Item G, one modification here on the section cited here. It's not section 8G, it's section, what is it? 8I. 8I. I know that makes a material difference to everyone here. So just to clarify that, Wanda.
My last contract is with UT Southwestern. It is for allograft tissue distribution, and the reason we are asking for this, we've already been using UT Southwestern's tissue bank for lenses and corneas. However, we're asking now to, and we've kind of been doing it on a one-off, but in order to have a contract with them to get better pricing. They are the only tissue bank within the area that can provide this particular thing that we need, and that is for cryopreservation of parathyroid tissue, which has to occur within 1 to 2 hours of surgery in order to be able to save the tissue. So we are asking to have an agreement with UT Southwestern's tissue bank for that purpose.
Any questions for Wanda?
I
Yes,
have a
DT.
question, because it said that for 2019 is 98,000 annually, but we're only seeing 196 for the next 3 years. So is that demand coming down, or I'm not looking at the right period or something? It's a 3-year term. Should it be 270?
Sure, find out, unless they're giving
Those
us a
numbers
better
don't add up.
rate over the 3 years, based on the pricing.
But it's a 3-year term.
Yeah,
For
in the
it said expected 196 over 3-year term.
yeah, in the actual
But the
contract, it's
contract
listed
is
as a 2-year term.
yeah.
2-year term, so.
Typo.
is that one? Okay.
Our agenda backup item, it misstates a 3-year when it should be a 2-year, because the actual contract says 2.
That's right.
Okay. Thanks for that clarification, DT. That's it.
Good hope.
33%
Wanda, well
discount.
done. All right, a free year. Thanks for the clarification. Any other questions for Wanda? I'll entertain a motion for this item.
Move approval.
Motion by Ms. DeBose, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Wanda. Oh, and just to clarify, this is
That's
a
sole
motion
source,
included
yes,
both
it was for a
the
sole
exemption
source,
and
okay.
the item. Thank you, Wanda. Starting? She said. Celia, good morning.
Good morning.
Good morning.
I'm presenting an amendment to our contract with MHMR of Tarrant County for adult and adolescent services. The amendment, original contract was for adult and adolescent crisis mental health services. And the amendments include additional monies for partial hospitalization for nonviolent offenders being released from jail as an opportunity for them to have their behavioral health issues addressed in a long-term setting. And so we've got partial hospital beds available should anyone be referred there. And so this is a little compensation for those beds. slots, excuse me, they're not beds.
Right.
And the other is an improvement in the medical quality of care for inmates in the county jail that are housed on the psychiatric part. We now provide a full-time RN that makes rounds several times a day, checking on whether an inmate is eating, drinking, and taking their medications, need assistance taking their medications and all of those things. So it's really bringing a higher level of medical care to those patients. And so this is compensation for that nurse's time.
Okay. Great. You heard the explanation. Any questions from Zelia?
Are the rates that we end up charging for this based on our current rates that we charge for Medicare, Medicaid, or are they based on what we would charge on connection? What's the rate base that we calculate the revenue on this on?
Well, we're actually in the process of fine-tuning the rates. I know that a lot of our rates are based on different payer sources. For example, Medicare pays a X amount, Medicare Managed pays an X amount, and those type of things. This is a little bit less than that.
So I would only just observe that when we do these revenue agreements with the county, that we probably need to always be in a position of updating our rate structure so that essentially the same price that we're having to pay for these services. Hopefully, we're not losing money on providing it, based on the current rates that we would pay in either one of those categories you mentioned.
I think it's critical that we update those rates. We bargain for the best rate we can get, but even when those rates fall short, I think the county and the taxpayers that contribute to this organization should know that. There should be a true
Absolutely.
transparency, because even with dealing with the state, and we've had that challenge, is we deal with the state, and there are people at the state level that think we're being compensated for what the care is.
Right.
And it is
Not
way
done.
under what that is.
Yeah.
And we've even had discussions with state and county folks, and no malintent, they're just, well, we thought you were being paid for those patients.
Well, the same thing, you know, when you look at the impact on us over the last 2 years from uncompensated care dollars continuing to be reduced constantly, the assumption is, well, JPS is just going to pick up the difference. Well, JPS is having to pick up the difference from the property taxes that people are paying on the JPS side of the equation to pay for it.
Right.
And part of you says, look, you know, to the extent that we're going to subsidize even more one of the county or anybody else when it comes to that, at least make sure we have the defense of a rate schedule that we can say those charges were based on. Because I think it is a matter of transparency. The concern is, even at the state level, the assumption is that JPS is just going to pick up the difference. And it just goes on and on and on.
I totally agree, and I think to that point, Trent, that's really important. If the Blue Ribbon Committee is calling for 200 more beds, and we understand the value of 200 more beds, let's look at the totality of the cost of those 200 more beds. And I don't want people to think, well, you're getting reimbursed for X amount of those beds.
Exactly.
I think they need to understand when we build that building, the additional cost we have, not only staff, but the lack of reimbursement we have for everybody that's in one of those beds. And Dr.
those
Hurd
become
can tell you
limiting
that.
factors to us. I mean, they limit how fast we can deploy our own capital program. And that's part of, I think, what we got to really focus on, because I think people don't understand that.
I agree. I agree. I think it is definitely the case. So, thank you.
Okay. So we, any questions for Zelia? Any more questions? I'll entertain a motion on item H.
So move.
Second.
Mr. Petty, second by Mr. Bose. All in favor, please say aye. Thank you very much.
Thank you.
Mr. Carr. Morning. Item I.
I would like to offer up for consideration, this is a sole source agreement with Brain Labs. We currently use Brain Labs for our trauma CAD software. This allows us as JPS orthopedic surgeons to map out the implants and to select the most appropriate implant for our patients.
Two parts, too.
We do about 240 of these cases per year.
This is our current provider of this.
Correct. It's current provider.
Any questions for Kenny? Yes, sir.
In the information part of this, it says that we included this in our budget. So we already knew prior or had a projected idea of what that was going to cost. We just needed to enter into the contract.
Correct, sir. We have a good idea. I mean, we've been using this company for many years. And every time there's a renewal, we actively seek to negotiate the best deals possible.
That's fine. And Kenny, to that point, for members of the board, I think that same discussion that you heard earlier would comply to Brain Labs and anybody else. Anytime we have a long-term agreement, we should be scouring the industry to make sure, is there competitive nature to Brain Lab? And then balance that with Trent's comment, and that is, okay, let's tell the finance committee, there is a new company, and within the next year, the next 2 years, and the next 3 years, we plan on going out for bid. Wouldn't make sense to do it midstream of the contract, or it would make sense to do it in midstream of the contract. What I want staff to be good at, and it's not about you, it's to all of us, is to make sure that we're presenting to the board what we can possibly do to know that we don't take sole sourcing for granted.
Correct.
That we've got a constant look. So I think their discussion will apply to all of you coming up when we have anything that is sole sourced. So that we're trying our best to understand the industry as well, because me nor board members are going to know what that industry. I'm happy you know, just for the fact that we use Brain Lab. To me, that makes it sound like a good contract rather than the no Brain Lab company. So I think it's good, but I think we ought to be doing our best to make sure we've got and can assure the board and our taxpayers that we are getting the best we can.
Robert, I think that's a really good timing of that statement, and I think it's a good message for our entire team, because as we gear up for significant capital purchases, which is the understatement of the century, you know, are we looking at our capital program, our equipment program, from the perspective that software vendors that provide services to that capital, you know, improvement is only one? Or if we choose this capital compete, there might be 6 different vendors that work from that. So now's a good time to be considering our policy direction on that, because we're about to spend a huge amount of money.
You bet.
On capital. And to the extent that we can begin really integrating a different philosophy when it comes to the MWBE component, it may make us widen our perspective a bit on how we go out and look at the initial capital purchases of this stuff.
I agree.
So it's a good time, I think, to make that observation.
Also, if I can go back, track on something Trent mentioned earlier, what is the determination, and I guess it's, I'm assuming it's per vendor, this is a 5-year agreement? I think we just approved one that was a 3-year agreement. Why are there differences in years?
Well,
I know different areas, but
Sure.
How do we determine
2 years, 3 years, 5 years.
Right, and especially since they're sole source.
Yeah. Well, I can't answer for everybody, but I can maybe give it a little more explanation for this one. We've been using this company for more than just 5 years, I mean, in the past. Our physicians as well as our caregivers are very comfortable with the imaging as well as the product that they're receiving. And that's a big judge for when we go out and start really actively looking and pursuing. Also, too, we can get out of the agreement for 3 years if we wanted to. It would cost us the dollars associated with that, and it makes it more advantageous for us if we intend to keep it for longer than just the 3 years, that we sign a longer agreement, because we will make up the difference in the 4th and 5th year in savings alone.
I think that's a good point, but to your point, Ralph, I think the other side of that argument is if we've been doing business with this company for this long, then there ought to be some sort of commitment that accompanies that
Yeah.
loyalty relative to this component of our business.
Yeah.
And it seems like it becomes really a negotiating, you know, in some cases, I'm not sure we have the leverage that we have, you know, with the software trauma vendor that we have, you know, with a Cigna. I mean, it's a different ballgame. But to the extent that we do have, you know, that sort of long-term loyalty with a particular vendor, it seems like that would be a reciprocal
Right.
expectation relative to complying with the district's
Every,
policies. and things
every
like
one of our contracts should be in the brightest light of day we could possibly have, where we say, 5 years makes this very smart, because renegotiating it and doing things differently and administrative cost and the quality of the product and what we've had the history on, this makes sense. This 3-year contract makes sense. We're actually going to do a 1-year contract. All of them should be justified, because we used to have a board member who we dearly miss, named Dr. Van Wagner, and she would have crowned you 3 times over for a 5-year contract. Because in her mind, contract should have been 1 month, and she was constantly on us. That was the other end of the spectrum. But I think it is helpful for us to be able to defend to a community that support this organization why it's, because 5 years may be the smartest time period ever. And this is not about you, it's just, that's where our contract should be, that we are able to defend each one from a cost standpoint, from a competitive standpoint, from a history of providing us services. So, well, your points are well taken, and so are yours. And I just think the lines and the alleys that we need to bump, you know, between are really challenging, but that's what I think this team should step up to do, particularly in light of an $800 million bond package.
And software is changing, so, and I know that a doctor, the orthopedic doctor might like this now, but if you bring in a new one, there might be another one that's out there doing the same thing that's better, and usually they upgrade software before 5 years, so.
Right, so, good point,
For
Ken.
me, this is like epic, man. You don't switch it down. Training, IT, integration, all that stuff. You just, it's a normal course of business. It's almost like using Microsoft, unless something went wrong. So
Sure.
I'm struggling with.
It's a balance, and that's where I think the discussion's good, because that's the balance that we as a staff need to present to you and the taxpayers.
To me, it's a automatic unless something is not right
Right.
on this one.
I think transparency is important, but there is not a, in my opinion, I think it should be more philosophical guidelines more than a one-size-fits-all, you know, a 3-year, 5-year, whatever. It depends on the vendor, depends on the service and the performance and a lot of other things. So, and what we can negotiate, you know? A 5-year deal, we might get a much better deal than a 2-year deal.
Right.
So, great questions, great conversation. Any other questions for Kenny? All right, entertain a motion on item I, and we needed 2 parts, so that motion to be one, an exemption from competitive bidding, and then approval for the item itself. I'll entertain any motion. Motion by Reverend Emerson, second by Mr. Nguyen. All in favor, please say aye. Aye. Opposed, motion passes. Thank you, Kenny. Item J.
So this is one I'm bringing back to the committee. It's the museum imaging, and we were lacking the diversity agreement, and so we worked with that company and were able to secure it. This is for a 3-year term for a total of $102,600. This system, it's an imaging system that allows the images for our trauma, also our spinal injuries, a lot of facial as well as cochlear implants imaging.
Okay, heard the description. Any questions for Kenny? We have a motion, and it's a 2-part motion that includes the exemption. We have a motion for approval, second by Mr. Bose. All in favor, please say aye. Opposed?
Thank you for getting the information.
Thanks for asking.
Motion passes. Thank you, Kenny.
All right, appreciate you.
4 from council. Any items?
Yeah, for the month of December, there were 26 contracts that were under $500,000.
Can you repeat
Month
that,
of
please?
December, there were 26 contracts negotiated that were under $500,000. Those are in the portal.
Approved by the CEO.
Yes.
Correct. Okay. That's all we have in open. We have one item in closed. So we'll take a 5-minute break, and then we'll reconvene in closed session.